And now I'd like to invite Dr. Eric. Dr. Eric is a very good friend of mine and a very good friend of all of us in our hospital. And he collaborates a lot with our program. He doesn't work in our hospital, but every time that he can, he come over and bring all his experience, especially in TE and also SP block to our students. Thanks, Eric. You're going to make comments now about neuromonitoring, right? So thanks, my pleasure.
Yes, thank you. The pleasure is all mine. Thanks for the European Association of Cardiothoracic and Intensive Care Anesthesiologists for this great seminar. So I'm gonna talk about. I don't have too much time, but I'm gonna talk about cerebral monitoring that was used during this case. I'm gonna talk about the most important aspects of neuromonitoring during this case. I have a conflict of interest with INVUS, assigned for research purpose in my institution. So, and I'm going not to show too much about INVUS here, but that's the only conflict of interest. So the BIS was first designed initially to avoid recall during cardiac surgery that is overrepresented along the years. So we have a incidence that range from 0.3 to 1.5% of the case. General incidence is something between these numbers. In the National Audit Project from the Great Britain was like 1 to 10,000 cases. So we have really important consequence, several behavioral disorders, psychological trauma, post-traumatic stress syndrome. So we have to avoid this. What's the problem in cardiac? I think most of the audience knows that alterations in pharmacokinetics, in pharmacodynamics, in the components of the membrane of the oxygenator, cooling and rearming, altering the solubility of the anesthetics, all influence here to put the patient at a higher risk for recall during CPB. We have great papers lately from Avidan. It's great authors showing that the incidence has decreased along the years, mostly because now we use several monitors and we integrated a multimodal approach to monitoring the anesthetics especially during cardiopulmonary bypass. That's the main talking here. So we use Untitled anesthetic concentration along with BIS monitoring, that the monitoring that's most studied in the papers. Obvious that there's a lot of monitors in the market nowadays, but we can see a perfect figure here showing the decrease in the incidence of this problem. We have a great problem during CPB, is that the concentration of the anesthetic and in relation to the end-tidal sevoflurane is not predictable. So it's a trend measure in almost times. Here's a paper recently published from Dante Pazzanese that I have to show here. We have different concentrations of end-tidal sevoflurane here in the end-tidal sevoflurane monitoring. And so this varies a lot with each patient. So each patient have great variations in this monitoring. So that's what I meant with unpredictable. And the authors show here that to ensure a BIS that is less than 50 we have to have what I consider in cardiac surgery especially during CPB, a high level of entitled self-run, which is for the D 95%, 1.39% of entitled. But you can have as low as, for example, here 0.6. So it's difficult to monitor during CPB. We have increased our monitoring capabilities here, especially with the introduction of the spectrogram. It's a visual analysis of the power of the frequency bandwidths of the EEG, which is very amenable to look at these modifications during CPB. And for visual analysis, you can almost see this about suppression because they have brain vulnerability, and you can use this as a probability of agitated patient if we decide to extubate this patient in room because there is not enough time for a patient with cerebral vulnerability to recover from the anesthesia effects inside a room. We have to send this patient to the ICU and give this patient time to recover some hours to avoid emergency delirium, which is quite different from traditional delirium that we can reduce with use appropriate doses of anesthetics when the burst suppression is related to death of anesthesia, that we can treat it and avoid the situation. Cognitive decline, we have to see more papers to get to any conclusion, and obviously awareness, especially during TIVA, but during inhaled anesthesia, I think a multimodal approach would increase the accuracy to avoid recall, as evidence showed along the time. Sorry for the time. Thank you very much.